Good evening, everybody. It is my great pleasure to welcome you this evening to the Billings Life webinar for NFA Week 2025. Our theme this evening is boosting your baby odds naturally. NFA Week is celebrated in August each year, and it's dedicated to helping women understand their fertility and manage it without the need for drugs, devices, or invasive techniques. And this is a topic that is very dear to my heart, and I'm delighted to be able to be here this evening and share this information with you all. Before we get started, we've got a little pre-quiz, a little poll. So give me 1 second to share our poll with you, and it will pop up on your screen. And should be showing up now. So take a second to read through these questions, see how much you know or think you know, and we will actually go through the answers for these and the reasons for them a little bit later this evening. Right, so I can see that almost everybody have answered the questions. So I will end that poll there. And as I said, we will bring that up a bit later in this evening. I just wanted to get you guys having a little think about some issues that women face and what you might know about it already. Now this evening we have in store for you a treat. We've got some fantastic speakers. We've got Dr. Jo Turner, who will be talking about leveraging the science of fertility awareness and giving us some research insights. We have Caroline Butt, who will be presenting on using the guidelines, that's the Billings Ovulation Method guidelines for conception, and Dr. Mary Walsh, who will be giving us some insights on a clinician's perspective. And at the end, we've got some testimonials that will be read out, and we will have time for a Q&A. So if at any time during these presentations you think of a question you would like to ask, please pop it in the Q&A. You will notice that the chat feature is disabled because this is a webinar, but you will be able to pop your questions in the Q&A and we will be able to answer those at the end. All right, so let's get started with Dr. Jo Turner's presentation, Leveraging the Science of Fertility Awareness Research Insights. Now, Dr. Jo is a GP obstetrician and rural generalist with a special interest in fertility awareness and infertility. He has undertaken fertility care, medical consultant, FEM medical provider, and Billings Ovulation Method training. He is active in teaching in the Joint Medical Program at the University of New England, assessing doctors for the Australian Medical Council, and undertaking women's and reproductive health research. He is one of the leaders of the World Organization Ovulation Method Billings Expert Research Alliance, which is the WOMB organization. I will hand over to you now, Dr. Jo.
Right. Right. Well, thank you for this opportunity to talk about this. It's just a delight to talk about the science and the research behind the Billings Ovulation Method, because it's been so much of it. There's been decades of research going into it. It's really quite a well corroborated method. So if we look at a study that was done here in Australia, it is looking at what we know about what we would like to know, looking about how much we know about fertility awareness. This study, conducted in women who were visiting their general practitioner with looking at fertility issues, found that 3/4 of these women agreed that timed intercourse could help with conceiving. So they knew that. They believed that that was the case. But looking at what these people knew, only a tiny fraction, 2%, believed that they themselves had a high awareness of their own fertility. So they knew what they wanted, but they didn't have the knowledge of it just yet. And in fact, 86% of them believed that they had low or no knowledge of fertility awareness. So it's demonstrating quite a gap there. More than 9 out of 10 of couples who presented to a general practitioner with fertility issues, fertility difficulties, believed that they should receive education from their doctor about how to conceive at the point that they first presented with fertility issues. So what did we find? Well, another study that was done around about the same time for the same project uh, looked at what the doctors themselves knew about fertility awareness. The, they found that the GPs responded to the survey saying that they had little education in fertility awareness. They weren't given much formal training in fertility awareness themselves, and therefore the GPs had a lack of confidence in being able to explain to the couples and the women anything about fertility awareness. So what did the GPs do? Well, they referred on to the specialists in fertility, who are the specialist obstetricians and gynecologists. These specialists are experts in artificial reproductive technology, ART, but they themselves also received little education in fertility awareness. So what were the conclusions of the study? Well, they concluded that the best outcome would be for couples who had trouble conceiving were that they should be referred to credentialed instructors in fertility awareness education. And this is what we're demonstrating tonight. We're showing that the Billings Ovulation Method teachers are these credentialed instructors, and it's backed by a good deal of evidence in practice. So let's go on to the anatomy. Let's go back to some basic anatomy. This is a schematic of a woman's ovaries. The ovaries is where the developing cells develop into eggs, and at the right time in a woman's cycle, the eggs will, at the time of ovulation, come out of the ovary and travel up here through the fallopian tubes, where hopefully, in order to achieve a pregnancy, they will be fertilized by a sperm that's made its way all the way up the fallopian tubes. In any case, the next stage along the woman's reproductive system is the uterus. The uterus is a muscular organ or structure which is lined by the endometrium. It's the endometrium that provides the sustenance for the growing embryo, the growing fetus. And it's the endometrium that, if there is no pregnancy there, it's the endometrium that sheds, and that's what causes the characteristic bleeding of menstruation. Down the bottom of the uterus is the cervix. And the cervix, it's more than what we just normally hear about. We normally hear about cervical screening for cancer, but the cervix is actually a complex structure. This complex structure was studied for decades by Professor Eric Oderblad, a pioneer and researcher in this field. And what he did is he looked at the structure of the cervix. He looked at what the cervix actually did. What he found was that towards the outer end of the cervix, as we came into the canal of the cervix, there were these folds around the side of the cervix, and these folds formed crypts. At the base of these crypts were specialized cells, and these specialized cells produce different types of mucus. And there's the key. The different types of mucus were found to have different functions based on their particular structure. So near the entrance to the cervix at the bottom end, we have these G crypts producing G mucus. Further up, we have P mucus, different types of P mucus as the ones up here, higher up. We have S mucus and L mucus. Now, one of Professor Oderblad's proteges, Menarguez, did a lot of work looking at the crystal structures under the electron microscope, and found that the different types of mucus are formed into different ultrastructures. The ultrastructures are what we see, what the mucus actually looks like. So, for example, the G crypts produce this G mucus, which didn't really have a structure. It was really quite amorphous. It just formed this sort of blobby stuff. And this blobby G mucus produced at the entrance to the cervix would block up the cervix. And when it blocked up the cervix, it would stop sperm from entering. So the G mucus tends to be present at times when a woman is considered infertile, when it's not a good time for her to become pregnant, because and that way the sperm are blocked and prevents pregnancy. Elsewhere, this L mucus forms these sort of right angle type structures. We'll get onto them in a minute. The P mucus forms these sort of fern shaped structures, and the S mucus forms these strings, these long strings of mucus. And if you can appreciate what happens to sperm when they encounter these different types of mucus, well, I talked about the G mucus and how it's just blobby and blocking. Well, if we look at this picture of S mucus right next door to some L mucus, and if you can imagine a sperm is coming up the cervical canal, it's being guided by this S mucus and taken in the right direction to travel up, travel up the reproductive tract. And so it's facilitated on its direction towards the egg to fertilize it. Whereas if we have some sperm which are not shaped the right way, are swimming in a bit of a funny way, going off sideways, they'll try and swim through this S mucus and then go off to the sides, and they'll get caught in this L mucus and they'll get trapped there, be held there. And in that way, the sperm that are not quite right, that should not necessarily be involved in reproduction, are taken off and are not going to be hopefully resulting in a pregnancy. But it's the good sperm that are going to be channeled up through the S mucus. So if we look at, this is a bit of a complex diagram, but it shows the different types of mucus present at the different times of the cycle. So if we say this is day 0, the day of ovulation, these are the days before ovulation and the days after, we call this the fertile window, where we know there is fertile mucus. And we look at the different types of mucus that are present. We can see the L mucus reaching a peak close to ovulation. We can see the S mucus reaching a peak around about the day of ovulation. And we know that it is these mucus types that are able to be determined by the woman in the Billings Ovulation Method and can be used to target intercourse for fertility. This study that was conducted in the United States looked at the fertile window again when good mucus was present, available to help with conception. And it looked at the hormone markers that indicated that fertile window was present, and it looked at the mucus that was present. The mucus that was present that was low in fertility is given the letter L. You can see it progresses into the fertile window. Then when we see the more fertile mucus, the L mucus, coming up into a peak, we have the high fertility, the H mucus, high fertility mucus in this study. And then the S mucus around about the time of ovulation at the peak fertility, which was for indicative of the peak fertility sign. Well, what did this show us? They looked at, they characterized two windows. They had the high fertile window in green and the low fertile, but still fertile, time in L, which is on either side of the high fertile time. They found that of the pregnancies that occurred when the couples had intercourse during the L time, 5% achieved pregnancy. But look at this. When intercourse occurred during the high fertile time, when the high fertile mucus is able to be identified, 87% of couples achieved pregnancy. So it demonstrates that timing of intercourse based on the different types of mucus can result in different fertility or different rates of pregnancy. This is our own research, which was published a couple of years ago, where we looked in Australia, all around Australia, we looked at 520 consecutive women who presented to Billings Ovulation Method qualified teachers. And we looked at data from 384 of them, which if anyone has done any sorts of research, they'll realize that 86% is a really good, really strong number of participants in this study. Now, when we look at this particular study, we'll see that half of the women or couples in this study had normal fertility. And that's defined as they've only been trying for less than 12 months and they haven't gotten pregnant in those 12 months, but we still consider that normal fertility. If a couple has been trying for more than 12 months and haven't gotten pregnant yet, they're given the diagnosis of infertility. And we had about 40% of the couples in this study were infertile by definition, but 10% further had prolonged infertility. These are couples who had been trying to achieve pregnancy for more than 12 months, for more than 24 months, and they hadn't gotten pregnant. So we had a good representation of normal fertility and infertile couples. So we looked at the couples and they were provided with teaching by accredited Billings Ovulation Method teachers. And When we look over the course of the study over 2 years, we found that of the normal couples, about 3/4 achieved pregnancy, which is a pretty good rate of pregnancy. If we look, however, at the couples who had a diagnosis of infertility, more than half these people who had not been able to achieve pregnancy before were able to achieve pregnancy during the study period. Not only that, when we looked at the 10% who had prolonged infertility, again, more than half of them were able to achieve pregnancy simply by using the Billings Ovulation Method alone. Now, this demonstrates that pregnancy can be achieved. It doesn't mean that everyone or every couple who are taught the Billings ovulation can achieve pregnancy. In fact, some of them didn't, but that's to be expected in a normal population. What we're looking at here is that the Billings ovulation method can help to boost the ability to achieve pregnancy. Then we examined the numbers of the women who did become pregnant, and of the 240 women of the 384 who achieved pregnancy, 30% of them achieved pregnancy in the first month. More than half, it only took 3 months before they were pregnant, and almost 9 out of 10 of those who were pregnant achieved it by 10 months. So in terms of acceptability and time to pregnancy, this demonstrated it was a very useful method to use. This graphic demonstrates another aspect of the data, which was looking at when intercourse occurred. And in the Billings ovulation method, you're taught when is the best time to have intercourse to try and achieve pregnancy. We look at intercourse during the fertile window, but not on peak day, and that'll be explained a bit later. And this window here, not during peak day. And it was found that intercourse during non-peak but fertile times of the couples with normal fertility, 2/3 achieved pregnancy by having intercourse on those days, and 53% achieved pregnancy on those days for the couples who were infertile or had prolonged infertility. Now, if we were to look at when couples had intercourse on the peak day, so they can target their intercourse for that day, it was found that 85% of those who achieved pregnancy with the normal fertility became pregnant on that day, intercourse on that day. And for those who had prolonged infertility or infertility of 12 months, 60% achieved pregnancy. So again, targeting intercourse on the mucus symptom has demonstrated a good achievement of pregnancy. So what are the key points? Fertility-focused intercourse. It's a good method to try and improve the ability to achieve pregnancy. That the research and the science has demonstrated that mucus from the cervix is key to achieving that pregnancy, recognition of it and using it. And that the Billings ovulation method is an evidence-based method to assist in achieving that pregnancy.
Thanks, Dr. Joe. That's amazing. What a great presentation. I'm always fascinated by, the science behind the structure and the function of the different types of mucus. And then you've got some amazing stats there too. I was particularly struck by some of those statistics about women reporting that they have little or no knowledge of, fertility awareness, and yet 92% of them believe that they should be receiving this education. So it's so great to be part of sharing that information this evening. It's time to move on to our second presenter for this evening, Caroline Butt. Caroline is one of our wonderful accredited Billings Ovulation Method teachers. She is based in Perth, and she completed her Bachelor of Engineering with honours and a Bachelor of Commerce in 2015 at the University of Western Australia, and started her journey with the Billings Ovulation Method in 2019 after she was diagnosed with PCOS and wanted a more holistic and restorative approach to her condition. Caroline is passionate about spreading the knowledge of fertility awareness to individuals and couples through her involvement in the Billings Life social media platforms, webinars like this evening, and the Education Committee. So I'll hand over now to you, Caroline.
Hi, everyone. Thanks for sharing that introduction, Carla. Just give me a moment whilst I share my screen with everyone. Screen 2. Play. Can everyone see this? Yep. And yes, it's wonderful to listen to Dr. Joe Turner give us a review of his research on the importance of cervical mucus, and timed intercourse in boosting pregnancy rates for both fertile and infertile couples. Tonight, I'll provide an overview of the guidelines for conception with the Billings Ovulation Method. And before we begin, we'll go through the true and false statements that you had earlier in the webinar. So I'll go through the first one. So if a woman's cycle is irregular, she can't become pregnant. So this first statement is false. Even with an irregular cycle, a woman can still achieve pregnancy. As with the Billings Ovulation Method, the woman can learn to identify when she is fertile, especially even when her cycle is not consistent. So the second statement, stress affects fertility. This second statement is true. So when a woman experiences sudden or severe stress, it may interfere her normal patterns of hormones, and this will be reflected in her menstrual cycle. So if she's charting, she'll notice that her ovulation is delayed, which means her menstruation, her chart's longer, and yeah, it'll be longer than normal. And the last statement, having intercourse every day will increase a couple's chance of conceiving. This third and final statement is false, and it's kind of misleading because it oversimplifies how conception works. As Dr. Joe mentioned earlier, timing conception matters more than frequency. So conception is most likely to occur during a woman's fertile window, and especially when the couple times intercourse during the peak, and thus intercourse every day won't necessarily boost a couple's chance of conceiving, especially when it's during a woman's infertile cycle. And go to the next slide. And so before we explore the guidelines for conception, I'd like to honor the pioneering scientists behind the Billings Ovulation Method. So their dedication has empowered countless families across the world for over 70 years. So the Billings Ovulation Method was founded by the two doctors, husband and wife, Dr. John and Dr. Evelyn Billings, see here. And with a collaboration with Dr. Eric Oderblad and Professor James Brown, who validated the method's effectiveness. This began as a professional partnership, which eventually blossomed into a lifelong friendship rooted in shared purpose and discovery. This is a quick overview of what's happening, what we'll be going through tonight, how it works, the 4 phases of menstrual cycle, cervix and hormones, and using the guidelines for conceiving. So we know from extensive research that cervical mucus is essential for fertility. So without mucus, pregnancy is not possible, as this fluid is needed to help the sperm travel up the cervix and envelop the woman's reproductive organs and reach the egg. And without mucus, the sperm dies very quickly. So Dr. John and Evelyn Billings realized that a woman would be able to recognize the change in cervical mucus by the sensation she feels at her vulva, said here. And with just this information, she can clearly identify when she is fertile and when she is infertile. So Billings' method teaches the women to tune into her sensations of mucus at the vulva and to keep a daily record of both the sensation and appearance of mucus. So for example, the sensation may feel wet, and it's like the days when a woman is experiencing a period, except when she checks, there's no bleeding. So as Billings teacher, we have this wonderful teaching tool. It's designed by another accredited Billings Ovulation Method teacher in Melbourne. And this is called the slide rule. And it's used as a representation of the menstrual cycle and its 4 phases. Just give you a quick overview. So the first phase of the cycle is menstruation. It's shown in this red section here. And it typically lasts 4 to 5 days. And most women would be familiar with this sensation, as the feeling of blood at the vulva can feel wet. And they can recognize this even, they can recognize that they have their period even before they've gone to see and look. So this marks the beginning of a new cycle. The second phase, highlighted here, is what we call the basic infertile pattern. It is pre-ovulatory infertility, and this phase of infertility occurs before ovulation. So it can be felt by women as a dry sensation with no discharge, which is shown in the green up here, or it may be felt as an unchanging pattern discharge with a sensation of dry or something else day after day, and it's shown in the yellow. It's characterized by an unchanging pattern. That's an important bit. So this phase of the cycle can vary in length. So it can be long, or it can be short, and is a part of the cycle impacted by stress, illness, breastfeeding, and other factors. The third phase of the cycle is fertile phase. It is represented by the white section here and the count of 1, 2, 3. So during this phase, women will feel mucus change from a basic infertile pattern and experience mucus patterns, which signifies the beginning of her fertility. So the mucus comes in the cervix and has many functions, including helping sperm to survive and travel. And conception, as I mentioned earlier, is not possible without fertile cervical mucus. So the fertile phase includes the peak, which we mark as an X, and 3 days afterwards, 1, 2, 3, in which conception is still possible. Ovulation usually occurs on the peak day, marked by the X, or up to 2 days after the peak has been identified. And regardless of how long or irregular a woman's cycle is, the fertile phase is usually about 5 to 8 days long. The last and final phase, we have infertility, so which are represented by the green in this slide rule. So she's infertile again from the morning or the 4th day after peak has been recognized. So it's no longer possible to become pregnant in this cycle. And in the normal cycle, menstruation usually follows 11 to 16 days after peak of fertility has been recognized. So it's important to note that a proper ovulation will only occur once in a cycle. It is possible to release more than one egg. However, if this were to occur, it will happen at the same time. All right, so we've gone through the 4 phases of the cycle. We'll go into the cervix and hormones. And during these 4 distinct phases, there are many wonderful and interesting things happening in a woman's body. So this image here, quite a lot going on, but I'll go through step by step with everyone. So the 4 phases of the menstrual cycle you see on the top section here. And then below that is a representation of a typical Billings chart, which is shown in either the sticker form or the stamped form. And the chart is also corresponding with what's happening in the cervix. You can see this image here. And below is also levels of progesterone and estrogen. So progesterone is shown by the orange and estrogen is shown by the blue line during women's menstrual cycle. So I'll just go through each phases of what's happening through each phase. So during menstruation, you can see estrogen and progesterone are low, cervix is open to allow blood to flow, and the woman mark on her chart with red stickers or solid dot. So she would use descriptions like wet or damp. So during the second phase, the infertile phase or the basic infertile pattern, cervix is closed with a thick mucus plug. Professor Oderblad highlighted that in red. Both estrogen and progesterone are also low, and the woman can sense at a vulva unchanging pattern of dry. So for this woman's chart, she charted with the green stickers or vertical lines and said dry. So during the third phase, the fertile phase, fertile phase, levels of estrogen and start to rise as follicles in the ovaries began developing. And at the time of ovulation, which is around here, levels of estrogen fall, progesterone rises, and the cervix is open, as you can see in this image here, and it's producing fertile mucus for sperm to travel through. And Dr. Joe showed really well in his presentation. There are several types of mucus produced by the crypts in the cervix, and this is observed by the woman as a changing developing pattern of discharge. shown in the baby stickers. And eventually it leads to a slippery sensation, which she's written here, slippery. And just the next day, slippery, and then followed by no longer slippery sensation, which she mentioned as tacky creamy. And during the fourth and final phase of the cycle, if conception did not occur, corpus luteum begins to degenerate and levels of estrogen and progesterone rises a little bit and falls, and eventually reaches the low levels. The start of the cycle and menstruation begins again. And during this time, cervix is closed again, egg is dead, and if ovulation hasn't occurred, and the daily sensation discharge may vary during this phase. However, the couple remains infertile for the remainder of the cycle. So that's a good. So we've learned about the 4 phases, the menstrual cycle, and how the woman's cervix and hormones interact during each of these phases. And with these wonderfully complex things happening in her body, she can simply chart every day and be able to accurately pinpoint when she is fertile or not. So that's a wonderful thing about charting every day. Now, it's time to go through the 4 rules of the Billings Ovulation Method and the guidelines for conceiving. So here you go. Let's start here. So there are 4 simple rules and 3 rules you apply before the peak, and these are called the early day rules. And then there's a peak rule that you apply once you identify your peak. Start with early day rule 1. No intercourse during heavy menstruation. You can see here. The reason why is ovulation might occur early, which means the mucus will start during the bleed. So we recommend couples to follow the early day rule guidelines, as the presence of heavy bleeding will make it difficult to identify if mucus has started during the bleed. Got early day rule 2. Alternative evenings are available for intercourse during the basic infertile pattern. So you can see here highlighted. So even when couples are trying to conceive, by restricting lovemaking to alternative evenings, it will ensure you recognize when fertility has begun. You can see this couple here, intercourse at the end of spotting and alternate evenings here. Then you have early day rule 3. When there is a change from your BIP, you wait. So once you've noticed a change from your BIP, you know your fertility has begun. But to optimize your chance of conceiving, we recommend waiting until you feel this slippery sensation, and then have intercourse while the slippery sensation is obvious for 1 or 2 days afterwards. So ovulation usually occurs on the last day of the slippery sensation, but it can occur as late as 1 or 2 days after the peak. So for example, you can see here the couple had intercourse in slippery days, and then 2 days after they recognized the peak. So to identify a peak, the woman must meet 3 criteria. She must identify a changing developing pattern of discharge. You can see from here, you've got damp, damp, wet, wet. This is just an example. And leading to a slippery sensation, got slippery sensation here, and followed by a distinct change to no longer slippery. So the distinct changes, she felt slippery, she felt wet the next day. And she will be able to mark her peak in retrospect. And finally, we have the peak rule. You may have intercourse at any time from the beginning of the 4th day after the peak until your next bleed. So by the 4th day after the peak, you are no longer fertile and there's no restrictions for lovemaking. And we recommend, as you're waiting for pregnancy to occur, it's important to not only make love when you are fertile, but also during other times during the cycle. And this helps to lower stress and at the same time helps nurture your relationship. And so in summary, there are 4 simple rules for the four phases of the menstrual cycle. And the most important thing is trusting your observations and keeping an accurate record every day and applying the rules effectively. So for those who are motivated and willing to learn with an accredited teacher, you'll have these skills for your whole life and have the option that has no physiological side effect. For me personally, I had a teacher guide me how to recognize my own unique patterns, and this made me feel reassured and confident. I learned to trust my own observations and was pleased to know that even with my irregular cycles from PCOS, I was still able to use the method and achieve pregnancy within the first month. And it certainly was something incredibly grateful and pretty grateful for me to come across all those years ago. So finally, those who want to start learning how to chart, I would recommend to reach out to one of the accredited teachers, such as myself, and book in-person or online session. And we'll be able to guide you through the process and help you gain confidence in using the Billings Ovulation Method for your whole reproductive life. And then we've got on this slide here the booklet that will revise on what you learned tonight. And experience tells us that an accredited teacher will provide you with a more thorough understanding of your unique cycle. So this booklet you can download for $5 on our shop, and it'll just give you a revision. And this is just our contact details here. And you can contact us on inquiries at the billingsovulationmethod.org. So if you've got any questions, feel free to pop them down in the Q&A. But yes, thank you so much.
Amazing. Thank you, Caroline. It's a wonderful presentation you've done, and I love how simple and grounded you are with the way you present everything, and it's clear that you are bringing both your knowledge as a teacher but also your experience as a user of the method as well, and that's wonderful. So now that brings us to our third and final presenter for this evening, Dr. Mary Walsh. Now, Dr. Mary Walsh is a Queensland graduate who moved to Melbourne in 1985 and has combined general medical practice with raising 4 children. She is a fellow of the Royal Australian College of General Practitioners, a FEM consultant, and has been an accredited Billings Ovulation Method teacher. Dr. Walsh has helped develop and has lectured in RAGP and RAOD accredited development programs in fertility awareness and restorative reproductive medicine application. In 2011, she founded the Fertility Assessment Clinic, a special interest clinic in the Manning General Practice in Melbourne, which offers medical advice and assistance in preparation for pregnancy and assessment and management of subfertility, infertility methods, and appropriate investigation and treatment to restore fertility. So welcome. Thank you, Dr.
Thank you, Carla. It's a great pleasure to be here tonight to discuss this very important topic. When I think back, my first involvement with the Billings Ovulation Methods started probably when I was in medical school, and when we were learning about reproductive biology and the hormonal changes and the changes in the symptoms and signs in a woman's body that you've heard tonight that Carla was talking about. But at the time, there was no emphasis given on how important this could be for a woman to understand all this knowledge. It was just a fact. So there was never any concept that it could be a useful bit of knowledge for doctors to have to impart to women. When I became married, my interest further developed because I was looking for a method of family planning that was healthy and natural and obviously simple to follow. And I was fortunate enough to move to Melbourne and to be taken to a lecture by Doctors John and Lynn Billings. And I was immediately attracted to the method that they were talking about, the simplicity, the essence of the method, which was quite simple, involving observations only, no need for anything else to be done. And the other thing that I was attracted to was the philosophy around it, the absolute respect for the woman's body, for an appreciation of the incredible gift that fertility is, the respect for a woman's health, the respect for the couple's relationship, the involvement of both partners in decisions about fertility, and just an overall approach to respect for the origins of human life as well, because embryonic life is a fascinating topic, and that had always fascinated me as well. So it all came together for me to appreciate just what an extraordinary gift this was to have as a doctor, to be able to offer it to couples. So the benefits you can see listed here that we've talked about already. It can assist women at all stages of their reproductive life, from menarche, the changes are happening in adolescence. It's so empowering to be able to teach teenagers about what's actually happening to their bodies, not to be alarmed by it, but to tune them into how they can monitor their own hormones by the changes that they'll notice in their bodies, right through the phases of wanting to possibly avoid pregnancy, to become pregnant, and then to the changes around perimenopause and menopause. And it is empowering knowledge. It allows women to understand their health, to monitor their reproductive health, which is a barometer of overall health, really. And in essence, without this knowledge, it's very hard for women to make absolutely informed choices about what they will do with their reproductive health in decisions around avoiding or achieving pregnancy. So often in my practice, I see couples who have never been offered this knowledge, and without that knowledge, they can feel that they are really shepherded into forms of family planning that they may not have chosen if they had known of other healthier methods. And of course, GPs are very well placed to encourage women to become fertility aware. But as we've seen in the statistics that Dr. Joe presented, it's unfortunately still not well covered in medical schools. So there's a general lack of knowledge among GPs and even specialists. So that's something that one would hope in the future would be addressed. So the next slide, we'll talk about what happened as I came into general practice with this knowledge, and was discussing very often with couples, or with women in particular, about the Billings method and charting their fertility. And over the years, my knowledge of the benefits of the Billings method grew, of course, and eventually the statistics that Dr. Turner presented tonight really highlighted for me the need for women and couples to be able to access not only teachers, but also doctors who believed in this method as well. And the statistics were so empowering, just to know that just teaching couples about the fertile time and when they could have intercourse to maximise their chances of conception, if that could be so effective in achieving pregnancy, then if you could add into that some medical assessment to try and help the couples who might have other medical problems that could be addressed to also further enhance their fertility, then that was worth offering. So there were other doctors around Australia who were doing this at the time, and after consulting with them and learning a bit more about it, how to offer it, we decided to open the fertility assessment clinic. And it was I had a set time in quite a large general practice that I work in. So this was a special interest clinic that I ran on a separate day. And we had Billings instructors come to be there while in the next room, so the couples could see me and discuss their issues and the fertility, and then had the option of actually starting to learn the Billings method to chart their fertility. And so for a while we had 3 doctors there and some Billings teachers, but then COVID came, and as you know, COVID certainly changed things, and now don't have Billings teachers on site with me, but they're certainly very available online or on the phone or in person through their website and through referrals. So what happens with this infertility patient pathway? Well, it can happen in 2 ways. Sometimes couples will end up learning about their fertility with a fertility awareness teacher, and if they're not pregnant, knowing their maximum fertility, and then still not pregnant, or there are signs in the charting of abnormalities, then they can be referred to a restorative reproductive medicine doctor for investigations and for possible treatments. The other way that it can happen is that they'll come to see a restorative reproductive medicine doctor, who will then suggest that they learn to chart their cycle to understand their fertility. And again, if they're not pregnant within 3 to 6 cycles, or there are abnormalities on the chart, and usually with a medical consult, investigations will be started anyway, just to check general health issues and preparation for pregnancy issues. And then if needed, treatments are offered, and the outcome is that health is hopefully restored, the disorder managed, and pregnancy will happen. So the next slide looks at what we'll look at with the infertility assessment. So as you know, there are female factors and male factors. 30% of infertilities can be usually often attributed to perhaps a female factor, 30% to male, and the rest can be a couple problem with factors on both sides, or possibly we never really can find out what the actual cause is. We know that the fertility awareness method chart is essential for the couple to know the times of maximum fertility, to time intercourse around that time, and for the doctor to be able to see that the couple know what they're doing, and that there's no sign of abnormality in the charting that could be a cause of concern. But it also, the signs of abnormality then make sure that the doctor knows where they're going with their investigations. And then we look at treatments, supplements, and medical management to restore general health, and in that way restoring reproductive health as well. And just a quick overview of the factors that we look at with female fertility. So lifestyle issues are a big one. So things like smoking, alcohol, any drugs, or stress, diet, weight, exercise, all of those general health issues are important with general health, and they're important, therefore, with fertility. So we look at general medical factors. There may be general medical conditions like previous cancer treatments or diabetes or thyroid issues that need to be thought about and managed. And then there'll be the gynecological factors. So there could be a problem with ovulation. It might not be happening very often. If we check the hormone levels, it might not be happening with good hormonal levels. General hormonal disorders could be upsetting things. There could be thyroid disorders. There could be some prolactin problem. There could be problems with diabetes and insulin resistance. Polycystic ovarian syndrome, which we're all aware of, is something that needs to be looked at and sorted out. Endometriosis is a big one. And interestingly enough, sometimes infertility is the only symptom of endometriosis. It seems to be an unusual problem, endometriosis, but sometimes women will have very obvious symptoms, but often it's a hidden, subtle problem that needs to be identified. And certainly management of endometriosis is important to assist with fertility. There could be problems with the fallopian tubes. They could be blocked, they could be scarred. The uterus, there could be polyps or fibroids or a septal abnormality. Could be problems with the cervix, which would then damage the crypts that produce the mucus. It's so essential that we've heard about so well this evening. There could be infections in the cervix that need treatment. There could be polyps. There could be past surgery to the cervix that has caused damage, and that all needs to be addressed. Infections quite commonly can cause scarring or blockage of the tubes. Infections of the cervix can contribute to cervicitis and abnormal mucus production. So they need to be analysed, looked for, and treated. And genetic abnormalities, which are necessary to be excluded as well, need to be looked for. And for the male, for male fertility, again, general medical issues can have a big impact on fertility. So the smoking, the drinking, the drugs, being overweight, not exercising enough, not eating healthily, all impact or can impact on sperm production and male fertility. General medical conditions, again, diabetes or hypertension or cardiac problems will need to be looked at and addressed. We know that excess heat around the scrotum can affect sperm production. That needs to be checked for. Again, infections, past history of mumps orchitis, a mumps infection of the testes could cause problems with sperm production, and sexually transmitted infections, again, can also lead to scarring and damage and problems. Sometimes medication, again, for the woman and the man, needs to be looked at. Some medication that are prescribed for general conditions, health conditions, can impact fertility as well. And again, there'll be some genetic conditions that might be a bit rarer, but would need to be sorted out. And so restorative reproductive medicine is that branch of medicine that understands fertility awareness methods and understands the ability to diagnose and help couples with fertility problems from observing the changes in the chart and guiding in investigations and management through looking at the chart and working out the best time to organise investigations and assist with management. So restorative reproductive medicine aims to actually identify and correct abnormalities, not just to bypass them, which so often can happen. It's identifying issues and restoring health and optimizing normal reproductive function. And that could be medical, it could be surgical, it can be medication supplements that might be necessary. It can be helping couples to remember that their general health is important. And I think it's important to know that even if after all of the investigations and all of the treatments and pregnancy still doesn't happen, then general health has been improved. And the psychological impact of infertility must be remembered as well. We work with psychologists who can really make a big difference for couples as they journey through this difficult time of searching for their fertility. And I think having the psychologist and the input from them really allows couples to perhaps sometimes come to an understanding of, their lives and the role that they do have in their lives with or without fertility. But the wonderful thing is to remember that this knowledge of fertility awareness is such a boost for those couples trying to become pregnant naturally. So this chart is just an example really of an abnormal chart. So just to look at this 41-year-old woman be married in 7 months wanting to achieve pregnancy. So she knows she's a bit older and she's obviously done the right thing and come to get some help at a time to get ready for pregnancy, which I think is a very important thing to do, is to seek help, even if you think your cycles are regular and normal. It's really important to remember preparation for general pregnancy, things like taking folic acid and eating and drinking properly, eating and not drinking alcohol anyway, and eating properly, being the right weight, and avoiding issues that can affect your fertility in the lead up to becoming pregnant. But this chart is showing a lot of abnormal bleeding and spotting and cycles. As you can see there's too many days of possible fertility, or that's abnormal mucus symptom, and too many bleeding days. So obviously this woman needs to be investigated. So the investigations were done, and you can see that, well, the next chart, the next slide rather, will show you that when the investigations were done for this woman, several things were discovered that she had high prolactin levels and just had a benign pituitary tumour. The prolactin levels can be lowered with medication. She was also found to be low in thyroxine, so she was hypothyroid. So that's often, I've had couples where that can be the only thing that's been holding them back from becoming pregnant. And once either one of those things is corrected, pregnancy and fertility can be restored and pregnancy can happen. And in this case, this woman had both of those conditions. So sorting that out certainly would help her to become pregnant more quickly. So just in conclusion, fertility awareness knowledge is an empowering thing at assisting women at all stages of their reproductive life, from menarche to menopause. Fertility awareness knowledge is empowering. It gives women the ability to understand and monitor their general health, their reproductive health, and it helps them to have that ability to make fully informed decisions about their bodies in achieving or avoiding pregnancy. And it's, as you've seen, it's an evidence-based method to assist in achieving pregnancy. So thank you. And it's, again, I said, a pleasure to be here tonight to help in this general discussion.
Thank you, Dr. Mary. What a wonderful presentation to hear. It's great to hear how useful it is. Yeah, wonderful perspective. Thank you. I know that we are a little bit short of time, but we're going to quickly have a look at a few testimonials here. Our wonderful accredited Billings Ovulation Method teacher, Kirsty, is going to read these. She's currently based in council, so she's another one. Wonderful teacher who's available to teach online or face-to-face. Pass over to her now.
Thank you, Carla. So the first testimonial tonight comes from Erin, who was 34 years old. And she says, I've been doing the Billings method for approximately 4 years. In that time, I successfully avoided pregnancy when I needed to and pinpointed my fertility when I was ready to try again. Despite a miscarriage, I got pregnant 1 year later after only trying for 2 cycles using the Billings method to conceive. I credit Billings with helping me to know my body and my cycles on a deeper level than just counting days. So as a couple, we had decided not to use chemical or synthetic contraception. The Billings method helped us to confidently understand the physiology of her cycles to determine the best opportunities for fertility. As a couple, we successfully conceived twice, and we plan to continue using the Billings method for family planning. We found it to be very safe and effective and highly recommend the Billings method to couples wanting to be in control of their fertility journey. And lastly, my husband Paul and I were married in December 2016. We were both eager to start a family. I had been diagnosed with endometriosis in 2009 and had had a second laparoscopy in 2011. For many years, I had been put on the contraceptive pill and told that later down the track I would need a hysterectomy. In a marriage course that we participated in prior to our wedding, we learned about natural family planning. This spiked our interest, and in mid-2017, after having no success in conceiving, we sought help from a local lady whom we knew taught the Billings Ovulation Method. The Billings Method was so easy to do and gave me a greater understanding of how my body worked. After a few sessions with Patsy, it became very clear that my cycles were regular and nothing seemed out of the ordinary other than my continued period pain. My husband and I sought help from a gynecologist and fertility specialist at St. Vincent's Hospital in Melbourne, hoping she would be able to help in our quest for a child and help decrease my pain. During the time in which I was seeing this specialist, I had my tubes flushed, and in March 2018, I had my third laparoscopy. During consultations numerous times, the doctor pushed IVF, stating I would be perfect for it, even though my husband and I had said multiple times we were not interested. After my surgery, I was told that that would be the last surgery I would be able to have for my endometriosis. Unfortunately, the surgery did nothing for my pain and we had no luck conceiving. In the meantime, our Billings teacher had decided that it would be a good idea for us to see Dr. Mary Walsh. She really wanted to help us and find out what was stopping us from having a child, focusing on my overall health. She took a holistic approach. We tried through charting to optimize conceiving together with taking supplements, blood tests, and progesterone after ovulation. I also began taking low-dose naltrexone, which really helped improve my chronic pain and overall well-being. After 2 years of no success in having a baby, Dr. Walsh then referred us to Dr. Brendan Miller. After a couple of consults with Dr. Miller, he told me he wanted to operate. Dr. Brendan Miller performed robotic surgery on me in July 2021. In March the following year, to our surprise, Paul and I discovered we were pregnant, and on 1st December 2022, we gave birth to our little boy Luke. Prior to meeting Patsy and learning about the Billings Ovulation Method, I had no real knowledge about how my menstrual cycle worked. After many years of being on the pill and putting up with chronic pain due to endometriosis, I was led to believe that contraception or the Mirena or a hysterectomy was my only answer. I often wondered to this day where we would be if we had not found the Billings Ovulation Method and the amazing people who helped us on our journey. I am quite certain that we would not have our little boy, and I question whether I would still have my uterus. My husband and I thank God for the gift of our little boy every day and happily share our story so that others may also benefit from natural fertility awareness. Thank you, Carla.
Thank you, Kirsty. Now I appreciate that we have gone slightly over time this evening, but we have had some questions come through on the Q&A. So if you have time, stick around because our wonderful panelists will turn their camera back on now. We can. If you do need to go, feel free to leave the webinar. The recording will be sent out with links. And you can check out the answers when that's. So to start off with, we had one question saying, what is considered day one of the cycle? Now, day one of the cycle is the first day of flow of menstruation. So once you have identified a peak and you know that menstruation is starting, that first day of flow, not just spotting that can sometimes happen beforehand, but the first day of flow is day one. We also had a question saying, what if you never have green or dry days and you always have some form of mucus or discharge? And what if you never have sticky ones? Can this affect the accuracy of recognizing the peak day? Now, obviously, to recognize the peak day, that slippery sensation is really important. So not being able to identify that is yeah. There are some other symptoms though to help recognize the peak. There is a swollen vulva that can sometimes. There is an enlarged gland that can sometimes feel at the top of the thigh that's on the side. So there are different things. But with the always having days of discharge, that's absolutely fine. Quite a lot of Billings parts will show BIP of discharge, which is just an unchanging pattern of discharge. Next question. Somebody's asked about if there are any comments about a woman's age. Oh, have we got Joe there?
Yes, yes.
Oh, here he is.
Woman's age does play into fertility. We know about that. Generally, the older a woman gets after sort of after late adolescence, the less her fertility is, particularly after the age of about 35 years of age. I have a slide that I can present from a poster we presented at a national conference one time. I'll just pull that one up. Yep, okay. Okay, if we can see this slide here, this is the groups again, the normal fertility, infertile and prolonged infertility. And just forget the boxes, but if we scroll down to here, which shows the pregnancies in each of these groups according to their years, you can see for the less than 30 age group, pregnancies were 81%, 73% and 67% as we moved from normal fertility to prolonged infertility. Similar trend seen for the 30 to 35s in the cohort of more than 35 years of age, moved from 73% in the normal fertility cohort down to 35% in the infertile and prolonged infertility. Overall, the numbers are encouraging, but there is a difference with respect to the age.
Thanks, Joe. We've got another question here asking, what supplements would you recommend for both a male and a female? Dr. Joe, would you like to take that one?
Sure. Look, supplements, it depends on what we're aiming at with the supplements. And that's where it's good to talk to someone who's trained in restorative reproductive medicine, as Dr. Mary Walsh was saying, because it really comes down to tailoring what you'd like to do. So, for example, if I speak about it from the male factor, there are studies that show that sperm motility will be affected by some supplements, whereas morphology or the shape will be affected by other supplements. So there's not sort of one supplement fits all. They have their different purposes, and that's where it's worthwhile having a discussion with someone who is trained in that field.
Thank you. Now, another question here, how can we calculate the fertile or infertile days if the period is irregular? Caroline, would you like to start with this one?
Yeah, sure thing. Hey, so I just want to reiterate, so the Billings Ovulation Method, we don't calculate the infertile and fertile days. We chart our mucus patterns day by day. And it's only when you consistently chart after several menstrual cycles, you start to learn your normal unique patterns. So that's when you start to recognize, like, okay, this is my fertile phase is about 5 to 6 days long. My infertile phase is about this. But as mentioned again, every cycle is unique and every woman's cycle is unique. So to answer that question, we recommend start charting. And most clients, including myself when I start learning, is after 2 or 3 charts of charting my menstrual cycle charts, I was able to confidently recognize my fertile days and to know, also confidently recognize when I'm infertile, and then use the guidelines to either achieve pregnancy or postpone pregnancy. So hopefully that answers your question.
I could just say it. I think it is a day-to-day assessment every day, isn't it? It's looking at the symptoms and saying, oh, is today a potentially fertile day or is it an infertile day based on the knowledge of the basic infertile pattern? So it's a day-to-day assessment, which helps because every day you're looking at it.
Thanks, Mary. The question asking what recommendations for if you're wanting to achieve a girl. I know that there isn't a lot of research around this. There are a few different theories. Maybe that's another topic of research you could go down, Dr. Joe, if you're feeling adventurous. Did anyone want to say anything about that one?
Carla, usually that's in here. The Billings method recommends 1 act of intercourse just as the mucus is becoming slippery, just before the peak. That's for the girl. And for the boy, just 1 act of intercourse just after the peak when the slippery sensation has just finished.
Thanks, Anil. There we go. I realise we've now gone 11 minutes over time, so we might need to wrap it up there, everybody. Those questions that might not have been answered yet, we will endeavour to answer in writing. So for now, I will just pop our final screen up so that everybody's got the contact details for getting in touch if there's anything you're still wanting to hear. And hopefully we can answer any questions that were made, and we'll have had an informative evening. And thank you very much to our wonderful presenters, and I hope everybody's gotten something out of tonight. Thank you, and we will be in touch.